Good morning to all of you. And at the outset, I would like to thank Suresh sir and the organizers for giving me this opportunity. So let's go into the approach to cirrhosis. So I'll be dealing with the definition, the various etiologies of cirrhosis, what is the underlying pathophysiology, what are the clinical features, the diagnostic approach to a case of cirrhosis, and management in general, and management of complications of cirrhosis. So, the first known description of cirrhosis was by Hippocrates in the 5th century, and the term cirrhosis was derived by René Laennec, the same doctor who had invented the stethoscope in 1819, from the Greek word skyros, which means yellowish color of a diseased liver, the tawny yellow color of a diseased liver. So, what's the global burden of cirrhosis? Why are we so concerned? In 2017, a study reported that 1.32 million deaths in the year 2017 due to liver cirrhosis, and that constituted 2.4% of the total deaths globally. And it's supposed to be the 12th leading cause of death according to the US data. So, we'll go to the definition. It's a liver condition characterized by liver scar tissue or tissue fibrosis and the conversion of the normal liver architecture to abnormal nodules. And what is it due to? Due to the long-term inflammation process of chronic liver diseases. So, it can be considered as an end stage of chronic liver disease. This is for an idea of a MASH is metabolic associated steatohepatitis. That's a new terminology for fatty liver. Just for a prototype, how a normal liver evolves into a fatty liver and then into the cirrhotic liver with the nodules, as we said. So this is again the NASH cirrhosis. This is just depicting how it evolves from a fatty liver, where you see vesicles in the So the first picture shows the fatty liver. You can see the fat globules there, and there is not much inflammation. That's the lymphocytes are seen. If you see the second slide, you see that there is NASH there. That is non-alcoholic steatohepatitis. So the inflammation has set in. And in the third picture, you can see that there is a slight nodular change with the fibrotic bands appearing. And in the fourth, we can see that there is complete end-stretching fibrosis with nodules. This is another picture, the low power view of the hepatocytes in the microscope. In the first picture, we can see a normal liver where we see no fibrotic bands. You can see the sinusoids in between the layers of hepatocytes and the central venule. Whereas in the second picture, it's a low power view of the cirrhosis. In this, the lobular architecture is replaced by cirrhotic nodules, and the nodules are separated by fibrous septae. So, coming to the etiology, based on the causes of cirrhosis, we can broadly classify this into viral hepatitis B and C. These are the commonest causes worldwide, and toxins can cause liver cirrhosis, such as alcohol and certain drugs such as methotrexate. Then autoimmune hepatitis leading to cirrhosis, cholestatic primary biliary cholangitis and primary sclerosing cholangitis, and vascular, just as in case of Budd-Chiari syndrome or sinusoidal obstruction syndrome. And there are metabolic causes like iron deposition in hemochromatosis, then the fatty liver leading to liver cirrhosis, as in case of NASH. And the new terminology, NASH means non-alcoholic steatohepatitis. The new terminology in 2024 is metabolic associated steatohepatitis. And then Wilson disease, where there is copper deposition, and few cases of cirrhosis where we can't find an etiology, we term it as cryptogenic cirrhosis. So, what's the natural history of cirrhosis? As we said, there is definitely a chronic injury that's happening. So, there is a chronic inflammation due to different inciting events such as the viral infection, alcohol, NASH, autoimmune disorders or cholestatic disorders, which will convert the normal liver. And the normal liver, due to this inflammatory damage and matrix deposition, it goes in for an early fibrosis. That means the fibrous septae will develop early, but if the liver is not properly cirrhotic, the fibrous septae start developing, and ultimately if the insult goes on, because we always have a, you can see lower down that there is a chance for resolution if we intervene, like if we treat hepatitis B or C at this stage, early detection, there is always a chance for resolution. But if the insult goes on for years, probably it can take, according to different etiologies, it can take even from 5 to 50 years. This goes on for a disrupted architecture, loss of function and aberrant regeneration, finally leading to the stage of cirrhosis. And when the cirrhosis becomes decompensated, that is when most of the liver functions are not taking place, and when there is hepatocellular failure, the liver cells, due to the chronic insult, they lose their function. And also there is an entity which is the most important, that is according to portal hypertension. That is the most important driver for the decompensations in cirrhosis. So when it reaches that stage of liver failure, when the hepatocytes fail and portal hypertension develops, then the patient goes in for a decompensation. And the ultimate pathway is of hepatocellular carcinoma. It is supposed that up to 1 to 4% of the patients with cirrhosis per year develop HCC. And so we have to be on the watch out for that definitely. And if the patient goes in for a decompensation and the MEL score goes high and the patient develops different types of decompensation, as we will come to later, the patient goes in for a liver transplant. So let's see the basic history. What is the spatial relationship among the different? So what is happening in the liver when there is cirrhosis? This is a normal liver, where you can see that the pink blocks are the hepatocytes. They have the bile canalicula's in between. So, and they have a sinusoidal surface where they are exposed to the sinusoids. They are basically small blood vessels. They are the end of the portal venules. So the sinusoids, usually when you see in healthy liver, the sinusoidal endothelial cells are fenestrate. That means they have small gaps in between, and that is what ensures a fine transportation of materials between the hepatocytes and the blood. So, and in just you can see that in the blue cells, with the fenestrate, just outside the cell, that is called a space of Dissay. And the space of Dissay contains a very important cell that is called the hepatic stellate cell. When there is a healthy liver, these stellate cells will be quiescent. That means they will not be active. They are quiescent. They are not active. And what happens when there is a prolonged insult is, so I'll just take you to the anatomy of the portal circulation. So just you can see that the portal vein is formed behind the neck of pancreas by the collision of the superior mesenteric vein and the splenic vein, and then that will branch into the liver, and the inferior vena cava drains this through the central veins, and that's a normal portal tract which we earlier saw. So these same hepatocytes are there. Those pink hexagonal cells are the hepatocytes, and this is a portal triad. The portal triad will have the branches of the portal vein and the bile duct and the arteriole. This is a schematic representation of a hepatic lobule. You can see that the portal tract is there towards your right side. It has the branches of the portal arteriole from the hepatic artery, the portal venule and the bile duct. And the portal venule will branch into small sinusoids, which the blood in the sinusoids bathe the hepatocytes. The hepatocytes are bathed in the blood of the sinusoids, and they drain ultimately into the vein which you see in the center, the blue vein, that's called the central vein, which ultimately joins the IVC. So what happens when there is a chronic insult? You can see the hepatocytes as a violet colored line there. And we saw what we had seen as a normal hepatic stellate cells which are quiescent, they are lying in the space of Dissay, and the normal sinusoidal endothelial cells with the fenestrate. But what happens in cirrhosis? See the next, the B slide. That is, the hepatic stellate cells are activated when there is a chronic inflammatory process, and they become the myofibroblasts. So once the myofibroblast stage is there, they go on depositing collagen in the space of Dissay. You can see that the activation of the hepatic stellate cells, and there's a deposition of collagen, and there is a loss of fenestration. In the first picture, you can see that there were more gaps in between the endothelial cells, but the second one, there is defenestration of the sinusoids. So this phase is called the capillarization of the sinusoids, and you can imagine that because of the deposition of the collagen in the space of Dissay, there is a constriction of the sinusoids. So this is the first pathogenesis that leads to portal hypertension, because blood is not able to flow properly through the sinusoids, and that will create a back pressure in the portal triad, which we saw earlier. So, we've all studied the Ohm's law earlier in our physics classes. So, what's the pressure gradient in a vein? So, pressure gradient, just as any vein in portal circulation, is a factor of the flow in the vein and the resistance. So, by this time, we know that there is an increased resistance in the sinusoids. Okay. So, there is an increased vascular resistance due to architectural distortion, and so the activated hepatic stellate cells has been depositing collagen in the space of Brisset, and the increased hepatic vascular tone also by 30%. And there is an increased portal flow also at this time, because in the liver there is a decreased nitric oxide and increased endothelin, whereas in the splanchnic there is another system which composed of the mesenteric veins, which are attached to the portal venous circulation. So what happens is, increased nitric oxide is being synthesized, and there is splanchnic vasodilatation. And when there is increased nitric oxide, it goes on to a hyperdynamic circulation, where the cardiac output is also increased, and it ultimately reaches splanchnic vasodilatation, and these vessels are decreased. They have a decreased sensitivity to vasoconstriction. So, the pathophysiology of cirrhosis, as we saw, is chronic liver injury, activation of hepatic stellate cells, collagen deposition, fibrosis, and architectural distortion. So, ultimately, due to the architectural distortion, it goes into the nodule formation, as we saw earlier. Then, sinusoidal capillarization, that is, loss of fenestrae and decreased pliability of the sinusoids, causing portal hypertension. And the loss of, and ultimately, due to all this, the nutrition to the liver cells will be impaired, which leads to a loss of hepatocyte function and synthetic and detoxification failure. This is another slide just to see what's happening in the liver. There is a chronic inflammatory liver injury, probably due to multiple factors which we said, like alcohol, hepatitis C, or NAFLD. These are the most important causes. Then that leads to hepatocyte death. Then, as we saw earlier, there is a fibrosis accumulation, and here you can see that the sinusoids and the central veins, that white bands are the collagen bands, that is the accumulation of the fibrosis. And you can see that the sinusoids in the center picture, they go for a vasoconstriction, and so then there is a restriction of the sinusoidal flow. Then also there is increased lymph production, so that in case of portal hypertension, when it goes significant, there is an extravasation of lymph into the peritoneum, ultimately leading to ascites, which you would have seen in the wards. So, and then which are the systemic effects of steroids? One is disrupted portal flow. When there is portal hypertension, there is always a form of systemic shunts which exist in our body, and many of them will open up due to the portal hypertension. So, how do we define portal hypertension? We'll be coming to in the later slides. So, because of the disrupted portal flow, many of these portosystemic shunts in different parts, such as the esophagus or the gastroesophageal junction or the rectum, they will open up and form varices, and ultimately, when the portal pressure goes above 12 mm of mercury, then that will lead to bleeding episodes. Then there's a decreased cardiac return and decreased central blood volume, then increased plasma renin activity, then kidney. But what happens is, here there is a hyperdynamic circulation and splanchnic vasodilation, but ultimately the kidneys usually suffer because there is a vasoconstriction of the arteries to the kidney. And due to the portal pressure, there is something called a gut barrier disruption and the gut bacterial translocation. That means the harmful bacteria from the intestines get into the blood through this leaky gut when there is a gut barrier disruption. So all this will add to the systemic inflammation which we see in cirrhosis. These are the things that ultimately leads to decompensation over the years. Now, then another thing is hepatic dysfunction. Okay, so we'll just see what's happening in the liver. In the liver, you can see on the left-hand side, in hepatic circulation, there is a decreased nitric oxide and increased endothelin 1, which leads to vasoconstriction within the sinusoids of the liver. Whereas in the splanchnic circulation, you see that there is increased nitric oxide. So increased nitric oxide leading to vasodilation, and also in the collateral circulations, there is a vasodilatation and new angiogenesis also taking place. So what's the new theory in the development of complications and organ failure in patients with cirrhosis is, the most important in the pathophysiology of cirrhosis is, as you said, portal hypertension. So that's where the balance is gone for the liver. So in cirrhosis, there is a portal hypertension that develops. As we said, there is a gut bacterial translocation and the pathogen-associated molecular proteins. Those are the byproducts of the bacteria, and there is activation of the pattern recognition receptors and release of pro-inflammatory molecules. So basically, it's a chronic inflammation that is going on, and due to this inflammation, there is more, and due to the portal hypertension, there is more and more of splenic arterial vasodilation and cardiovascular dysfunction, and this will ultimately lead to kidney dysfunction, hepatopulmonary syndrome, then hepatic encephalopathy and adrenal dysfunctions. And due to the liver injury, there will be damage-associated molecular proteins that are released from the liver also, and that will also add to the systemic inflammation. So let us just try to understand more about portal hypertension. We were telling about portal, but how do we define portal hypertension? Portal hypertension is actually, there are indirect methods or non-invasive methods of portal hypertension, but ideally, portal hypertension is defined in research settings by the HVPG, that is hepatic vein pressure gradient, and that is the, you can see that if a catheter is introduced into the IJV through the hepatic vein into the terminal part of the hepatic vein venules, and in the middle picture you can see that's a balloon is inflated there in the terminal part of the hepatic vein. That is called the wedge hepatic vein pressure. When a balloon is wedged there and they are taking the pressure of that. So the wedge hepatic venous pressure is considered to be equivalent to the sinusoidal pressure, and then a free hepatic vein pressure will be taken within the terminal part of this hepatic venules. And the difference between this, so essentially it's the difference between the sinusoidal pressure and the hepatic venous pressure. So that is called the HVPG, or the hepatic vein pressure gradient, the gradient between the sinusoids and the hepatic veins. So when the HVPG, usually the HVPG is less than 5, when it is more, we call it a sinusoidal portal hypertension, because we are trying to measure the sinusoidal pressure through by this HVPG. And so we can see that these are different stages of chronic liver disease. So in the initial stages, it might be just a histological diagnosis. Then it goes from in a stage of no cirrhosis to compensated cirrhosis, where most of the hepatic functions are taking place, to decompensated cirrhosis. So in compensated cirrhosis, if we tell about the histology or the non-invasive, it is a F4 up to the F4 stage. The fibrosis has different stages from F0, F1, F2 up to F4, and once it is F4, we call it cirrhosis. And once it is F4, that means the septa are very thick. There is a high risk of decompensation, and mostly at this stage, we should understand that that is called a clinically significant portal hypertension. You can see in that to have a higher risk of decompensation when the portal pressure is more than 10 millimeters of mercury. So when the portal pressure is more than 10 millimeters of mercury, it's called clinically significant portal hypertension. We said that portal hypertension is more than 5 millimeters of mercury, we call it portal hypertension. But when it becomes clinically significant, that means the patient can go for decompensation if there is any further insult. So that is called clinically significant portal hypertension. That's a new terminology. And then it goes, see, when it is more than 20, more than 10 basically, but more than 12 we can have variceal bleeds, and more than 20 of this HVPG we have worse outcomes with the patient, and mostly it is seen in decompensated cirrhosis. So there will be a first episode of decompensation where one event might be there, and this can go into further decompensations with more than one events. So how do we diagnose clinically significant portal hypertension? Is HVPG being more than or equal to 10 millimeters of mercury. So there is a higher risk of hepatic decompensation, and this is a stage where we have potential therapeutic implications. And in compensated cirrhosis, so there can be two stages. One is the patient can be with clinically significant portal hypertension, and the patient can be without CSPH. That's the two stages of compensated cirrhosis. And once the patient has a clinically significant portal hypertension, the patient definitely has a high risk of decompensation in the form of ascites, hepatic encephalopathy, or major bleeds. So, can we predict? So, we were telling about HVPG, which is definitely an invasive method whereby we define portal hypertension. But can we have a non-invasive prediction of this clinically significant portal hypertension? So according to for portal hypertension, the internationally accepted guideline is the Babino guidelines. So according to the Babino 7 guidelines, they are describing that instead of going for a diagnostic upper GI endoscopy in cases of in which we suspect a clinically significant portal hypertension, we can see if the liver stiffness measurement, this is measured by the fibroscan. It is a new technology whereby the ultrasound, like the sonic waves, are used to measure the liver stiffness. So if the LSM values are between 20 to 25 kPa, it is expressed in kPa, kilopascals, and the platelet count is less than 1.5, or the LSM value is between 15 to 20 kPa. If the LSM value is less than 15, you can, most of the time, you can rule out cirrhosis. So the LSM values are between 15 to 20 kPa and the platelet count is less than 1.1. So if the patient satisfies any of these criteria, you can say that there is a CSPH with a positive predictive value of more than 60%. So finally, coming back to what happens in liver when there is scarring. Okay, scarring impairs liver's ability to control infections. You know that Kupffer cells in the liver, they play a very major role in the innate immunity mechanism. So in the control of infections, so properly the liver can't remove bacteria and toxins from the blood, and the processing of the nutrients, hormones and the drugs which we take in is all impaired. And liver makes proteins that regulates blood clotting, so blood clotting becomes impaired. And bile helps to absorb the fat and the non-soluble vitamins. Here there is a problem with the, we saw that the bile ducts are getting compressed in the portal tract, so there's a problem with the nutrition also. So what are the clinical features of cirrhosis? Up to 40% of the patient with cirrhosis in the initial stages, they will be asymptomatic. So clinical features early, you can see asymptomatic, or patient may be having non-specific symptoms like fatigue or anorexia. Then, but in the late stages, when the patient goes in for a decompensation, patient has jaundice, fatigue, sometimes weight loss. Weight loss is especially seen in case of patient developing further complications like sarcopenia or HCC, and also muscle wasting. So, what are the, and you can identify the signs of portal hypertension once the patient develops clinically significant portal hypertension, splenomegaly, ascites. You could have all seen ascites patients in the wards. Then varices and hepatic encephalopathy. Once it progresses to the stage of severe hepatocellular failure, the detoxification process is impaired and the patient goes in for a hepatic encephalopathy, where the patient can be at different stages. Like sometimes it can be an overt hepatic encephalopathy, or it is called, there are two stages basically, covert or overt. Overt means you can identify the patient with confusion and the asterixis, the flaps tremors, whereas a covert hepatic encephalopathy you can identify only with the psychometric testings. So the signs of cirrhosis which we usually see in the patients. So generally, a patient might have jaundice, fever, loss of body hair, and in case of compensated cirrhosis, you can find many times sandalismus. I'll be coming to in the next slides. Parotid enlargement, acylidinosis, then spider nevi, gynecomastia. Sometimes in case of alcoholic cirrhosis, early stages you can have a large liver, but mostly shrunken liver, it's difficult to palpate in many cases. In splenomegaly, once there is a portal hypertension. And once the patient, and then the liver palms, the palmar erythema is there, impotence, contracture, then testicular atrophy is another main thing which you can identify. Then for decompensated cirrhosis, you can identify the features of hepatic encephalopathy. Then ascites, you can see the dilated veins in the abdomen, they are called caput medusae, and pidal. So what is spider nevi? That's a dilated arteriole with multiple radiating vessels from the central arteriole. And if you try to put a pressure on the central arteriole, you can see that it blanches. So it's believed that it's a relative estrogen excess that mediates this vasodilation, and they are typically seen in the territory of the superior vena cava. So you always look for spiders in the chest or the upper trunk. Pedal nails, the pink and white nails of liver cirrhosis, and those are the caput medusae. The dilated veins around the umbilicus which occurs in portal hypertension. Another common clinical sign that you come across in cirrhosis is gynecomastia. It's a hallmark of feminization because when there is liver cirrhosis, there will be that's a stage of hyperestrogenemia. and there is an increased peripheral conversion of testosterone to estrogen. So, how do you identify true gynecomastia from obesity, from gynecomastia due to obesity is there is a palpable enlargement of the breast glandular tissue under the areola. So, you should always see for that. It's whether gynecomastia is due to due to obesity, fat accumulation, or it's a real palpable enlargement of the glandular tissue. And many times, most of the times, it will be tender with enlargement and pigmentation of the areola. And then you would have all seen, especially in cases of alcoholic cirrhosis, you would have seen paroidal enlargement. It is asymptomatic and mostly does not affect the salivary gland function. Mostly seen in alcoholism and alcoholic cirrhosis is a bilateral enlargement of the paroidal gland. Then we all have seen jaundice, which is yellowish discoloration of the sclera. Then this is a palmar erythema. So it's a symmetric, non-painful, slightly warm and non-scaling erythema of the palms. It occurs most frequently in the thenar and the hypothenar eminences of the palm. It is pronounced in palms due to higher density of AV shunts in the palms, and the soles of the feet can also be similarly affected. Then debutant's contracture, always look for debutant's contracture. It is due to the thickening of the palmar fascia, which becomes ultimately shortened, mostly affecting the small finger and the ring and the little finger. Then sandalasmas. The yellow plaques along the medial canthal regions of the upper eyelids, and results from perivascular infiltration of the mono and multinucleated form cells with lipid-laden cytoplasmic vacuums. And we all have come across petechial hemorrhages. Maybe the first sign of thrombocytopenia. Mostly look for petechiae in the lower limb. It can also occur in the upper arms and abdomen. Then coming to the laboratory evaluations. So what do we expect in a case of cirrhosis? The liver function test will be mostly showing a mild hyperbilirubinemia. Then there will be mostly the SDOT will be more than PT. That's a usual pattern that is seen. Then the INR will be, and there is hypoalbuminemia because liver produces proteins for the body. So we definitely expect a hypoalbuminemia. Then INR will be elevated. As we said, the clotting factors are not being produced. So INR will be elevated. And due to the portal hypertension, there is a splenomegaly that is taking place, and there is a thrombocytopenia. Then can we identify liver cirrhosis with imaging? Yes, because it is by definition it is basically a histological process, but we don't always need biopsies. Biopsies are needed only when diagnosis is uncertain or the etiology is uncertain. Mostly in cases where we suspect some overlapping etiology, we are not able to define the etiology at the onset, then we go for biopsies. So otherwise, always the diagnosis of cirrhosis is by one of these imaging modalities, of which the most common we see is ultrasound. Then the second imaging modality that's newly come up is the elastography. I told you about the fibroscan machines where we can measure the liver stiffness. And are there other modalities? Yes, CT and MRI can also diagnose cirrhosis, but we don't use them always for the diagnosis at the outset. Then there are non-invasive fibrosis scores also, which are depending on the blood parameters. That's the APRI and the FIFO scores, but that's mostly used in the pre-cirrhotic stages, where we see whether we should suspect for cirrhosis or not. That stages will be used. So how do we find a normal versus cirrhotic liver in the ultrasound? Here you can see that there's a homogeneity of in the first picture it's a normal liver. So if you see the liver capsule as a white line there, it is regular. It is regular, and there's a homogeneous echogenicity of the liver, and usually the liver echogenicity will be similar to the kidneys echogenicity. That's a usual one. In cases of fatty liver, the liver will appear more bright in the ultrasound. Whereas in the second one, you can see that regular outline of the liver margin has been turned into an irregular one. So it's a rough liver margin. And this is a patient who has decompensated with ascites. That's what you see there. Above the liver capsule, you can see a black area. No? That's the ascites. And then you can see the heterogeneous liver tissue. So this is the usual appearance. And in ultrasound, we also can go measure portal hypertension by measuring the portal vein diameter and the portal flow. So the portal vein diameter will be always more than 12. Usually we keep a 12 millimeters. Portal vein diameter more than 12 millimeters is suggestive of portal hypertension. and then I don't have pictures for that. Then we see the spleen also. When we go to the left hypochondrium, once we find these findings, we go to the left hypochondrium, we measure the spleen, and if the length into width of the spleen is more than 50, if the product length and breadth is more than 55, it is hypersplenism. Okay, that means it is portal hypertension. That is splenomegaly. So splenomegaly is the length and breadth is more than 55, and the portal vein flow will be we can measure it with the Dopplers, and the portal vein flow will be less than 16. So that is how we define portal hypertension, by the portal vein diameter, then by the splenomegaly, and by the portal vein flow. That is how we define the portal hypertension ultrasound. Then this is just to show how a liver appears in CT. Here you can definitely appreciate the shrunken liver there in the left upper part. Then we can see the collaterals there. Those in the second picture B, you see the collaterals in the gastroesophageal junction. These are the portosystemic collaterals, and this patient is likely to bleed. In the last picture, you can see the splenomegaly. Okay, the spleen is very much enlarged there. So how do we work up? Once we understand that the patient is having cirrhosis, the first attempt will be to understand, because we said it's a chronic inflammation and an inflammation mediated fibrogenesis of the liver. So we have to identify what is the culprit first. So usual culprits are the viral hepatitis. Then we definitely take a history of alcohol. So viral hepatitis serology is for HBsAg and HCV, preferably by ELISAs. Then the core antibody. Sometimes the patient might be having an occult HBV where the core antibody will be positive. HBsAg might be negative. In those cases, you go for a PCR. Okay. Then the DNA PCR in case of hepatitis B, or an RNA PCR for hepatitis C. And then if a suspected case of but all the cases of cirrhosis, actually we go for all these evaluations, serum ferritin, then autoimmune hepatitis markers. ANA, then there are different anti-LKM1, anti-LC1, those are the different antibodies that are positive in autoimmune hepatitis. And sometimes there can be combined etiology also. So if you find that the patient is having taking alcohol in serogenic doses, but the patient is probably very young, he is developing cirrhosis at the age of 32. So there might be some of the underlying players there, and always evaluate for Wilson's disease also. I forgot to put that. Actually, serum ceruloplasmin also has to be measured in all cases of cirrhosis. So if you suspect that, because alcoholic cirrhosis will take much more time to, only due to alcohol it takes much more time. So when a young patient, even with a history of alcohol intake, you should evaluate whether there are any competing etiologies. And then you should go for the complete blood count, LFT and prothrombin to stage the disease, and INR also. So coming to the management, general management is you should always treat the underlying etiology. So taking away the insult, that's the best thing. We found that especially in early cirrhosis, there is always a chance for recompensation. So then regular monitoring of complications is needed for any cirrhotic patient, and you should always, whenever the patient comes for a repeat visit, just make sure that they are not taking any hepatotoxic drugs, because many of the NSAIDs, they will be available OTC, over the counter, and we will not be knowing. Patient, when they come with decompensation, they might be going for a dental extraction or something, they're getting NSAIDs without their knowledge also. In many cases, and they go for decompensation, finally come with a kidney injury. That's the scenario where we meet many of our patients. So always you try to educate the patient that without your knowledge, they should avoid taking any drugs otherwise, and always alert a consulting physician that they're having this underlying problem when they're going for some other consultations. And it's always good to vaccinate your cirrhosis patients for hepatitis A, B, pneumococcus and influenza. So, do we have some predictive models in cirrhosis? When we see a patient, how can we predict? The most common predictor that is used is a CTP score, which you all know, in which we check for serum albumin, bilirubin, prothrombin time, ascites and hepatic encephalopathy, and we divide the patients into classes A, B and C, which will be coming to later. And why do we divide them? Because we can predict the 1 to 2 year survival rates. For example, if the CTP class A, the first year survival rate will be 100% and 85% in 2 years. Whereas if you see child B, they have an 80-60% in 1 and 2 years. So the survival rates in 1 year and 2 years comes down drastically as the CTP stage advances. And there is another important score that's called a MEL score, and recently they have made it the MEL sodium, incorporating sodium values also into this. That's a model which is used to predict short-term mortality, especially 3 months, and that is based on bilirubin, creatinine and INR, and that's mostly for also for the liver transplant evaluation. Based on the MELS sodium score, you decide whether to get the patient into the transplant list. So this is how we calculate the CTP score based on bilirubin, albumin, INR, ascites, and NCUF, and the degree. Okay. And another thing is, this is the you have different platforms where you can put all these values and you can calculate them online. This is for an example of the MDCal, where the first it's showing that when I put some increased values for all this, it was showing that the patient has a child class C cirrhosis and the life expectancy seat is 1 to 3 years. Okay. Where the second second screen is the MEL actually. That is, you can enter everything and then you can get a MEL value and it will predict the short-term mortality of the patient. So CTP is for long-term mortality, 1 to 2 year mortality, and MEL is for 3 months short-term mortality, and for incorporating the patient to decide whether a patient should go for transplant. And usually we suggest transplant or referral for liver transplants at a MEL score of more than 15. So what are the complications? The complications of cirrhosis, they can be divided into complications of portal hypertension. We saw portal hypertension will lead to gastroesophageal viruses or even rectal viruses. Then an entity called portal hypertensive gastropathy. I'll show you the picture later. Then hypersplenism and ascites. Then whenever a patient with liver cirrhosis decompensated, especially with ascites, is admitted and you see that the liver function tests are rapidly deteriorating, always keep in mind the patient might be having a spontaneous bacterial peritonitis. And we'll come to those later, I'm just telling you. Then second thing is hepatorenal syndrome, then hepatic encephalopathy, hepatopulmonary syndrome. So liver has an influence on all the surrounding organs. That's why due to cirrhosis, you can have problem with your brain, kidney, even cirrhotic cardiomyopathy can come, then hepatopulmonary syndrome, portopulmonary hypertension, and the latest entity which has come up is sarcopenia, muscle wasting. And as we know, there is coagulopathy, then osteopenia, osteoporosis is very common, so always screen your patients and try to see for that also whether the patient has osteoporosis, and hematological abnormalities which we know, anemia, then there can be thrombocytopenia, neutropenia, all these as a part of hypersplenism also. So complications of portal hypertension. We earlier said this actually. The clinically significant portal hypertension, actually at HPPG is more than 10. We said no clinically significant. But when the HPPG is more than 12, you can go for it is high propensity for variceal bleeding the patient. And varices are present in child A. If you see 42% of the patients can have varices, whereas see that in child B and C 72% of the patients have varices. And what is the median survival rate for ascites and hepatic encephalopathy? If a patient develops ascites, the median survival is 1.1 years, and for the hepatic encephalopathy, it is less than 1 year. Then, how can we prevent decompensation? So, we told about what are the different types of decompensations. The first and foremost, when the patient comes to you, try to remove or suppress the primary etiological factor. Reduction in the HPPG and that will definitely reduce the risk of decompensation. And regarding the most common etiologies for HCV infection, we have the directly acting antivirals, and we can always aim at a sustained virological response. What is sustained virological response? We treat the HCV according to the stage for either 3 months or 6 months, and then at 1 year the patient is free of the virus. That is called the sustained virological response. Then chronic hepatitis B virus infection, we have very good antivirals for hepatitis B suppression like the tenofovir and the entecavir. That are the most commonly used antivirals for hepatitis B. And for alcohol-related liver disease, you know, it's a long-term abstinence from alcohol. And if the patient needs a psychiatric support, definitely offer that also. So, how do we manage varices? Varices, either we can go for a primary prophylaxis. Primary prophylaxis means patient has in blood. We found that there is a clinically significant portal hypertension. So, what's our aim is to give non-selective beta blockers and prevent the further. That means we are trying to reduce the HPPG there and trying to reduce the enlargement of varices and further bleeding. Second thing, we always come across the management of acute variceal bleed. And always after the management of the acute varicose bleed, once you manage it successfully, always go for a secondary prophylaxis to prevent further rebleeds. So this is the primary prevention in the upper GI endoscopy. In case you find that there are no varices, you are supposed to repeat the endoscopy at 2 to 3 years. And now the non-invasive predictors, as we saw earlier, the liver stiffness and the platelet count is there. So you can come to a conclusion if the patient really wants to avoid EGD at the early stages of cirrhosis, we can also go for a non-invasive. Otherwise, mostly it is upper GI endoscopy. And if there is significant esophageal varices, you start them on non-selective beta blockers. And nowadays we don't go for preemptive EVLs at first. If we try to give medicines first, only the patient bleeds most of the time, we go for a varicose banding. So which is the non-selective beta blocker that is preferred to reduce this HDPG? It's carvedilol. It is a non-selective beta blocker with intrinsic anti-alpha-1 receptor activity. So there's a greater reduction in portal pressure than the traditional non-selective beta blockers. And it also has, carvedilol's additional advantages, it has a beneficial action on the alpha-1 receptors in the liver that reduces the portal collateral and the intrahepatic resistance. We said according to the Ohm's law, intrahepatic resistance is very important. So it has effect on both ways. So beta blocker, also an alpha-1 blocker. So then next is one of the most common scenarios we come across in the clinics, emergencies, is acute varicose bleed. So if we suspect that the patient has portal hypertension, patient might be a known case of CLD, or sometimes we find that as the blood results come up, we see that the patient has thrombocytopenia, hypoalbuminemia, so you are suspecting a portal hypertension. So always it's the emergency management, initial assessment, history, physical examination, resuscitation and ABCs. And then you should, in case you are suspecting this, always start the patient on terlipressin. If you have a suspicion of this one, start the patient on terlipressin. And then always, as we said, there is a leaky gut barrier and cirrhosis, so it is always better that to avoid going into sepsis, you always intervene with an antibiotic at the start itself. So if it's a suspected varicose bleed, always give mostly it is ceftriaxone IV or Gramoli which we give. And you go for an early diagnostic endoscopy, and the time period defined is within 12 hours. So always stabilize the patient, go in for an early diagnostic endoscopy within 12 hours of presentation, whereby we confirm a varicose bleeding and go for an endoscopic therapy. Most of the times it will be endoscopic band ligation. And there are other modalities also like the endoscopic sclerotherapy, which is less often used. And I'll just come to that. So after this endoscopic therapy and EBL, which is possible in most of the cases, we go for a maintenance vasoactive drug therapy. So how many days? For 3 to 5 days, and antibiotic prophylaxis will also continue for that much time. And most of the cases, more than 85%, we will be able to control that episode with the endoscopic therapy and the vasoactive drug therapy. And if in 15% of the cases the patient has further bleeding and you are not able to tackle it endoscopically, there is a rescue therapy which is called the TIPS. So initial management of a patient, this is what I said earlier. And one thing, conservative strategy for axial transfusion. So we should aim at a hemoglobin of 7 to 8 gram per deciliter. The patient has some comorbidities, you can go up to 9 max, but it is usually between 7 to 8. Over transfusion has been found to be not a good prognostic factor in these cases of acute varicose bleed. And routine FFP should we give? We should not give. Avoidance of FFP and cryoprecipitate. But the most important thing is the prompt initiation of vasoactive therapy with terlipressin. And also antimicrobial prophylaxis. And within 12 hours we said. And there are different type of varices like the gastroesophageal varices, or it is an esophageal varix or ectopic varix, it differs. So I'll just say, most of the cases we find esophageal varix, but sometimes we find that the esophageal varix will be extending along the lesser curvature. We see the varices, they are called the gastroesophageal varices. And if they are extending along the lesser curvature of the stomach, they are called the GOV1. If they are through the greater curvature, they are called the GOV2, and there's a slight difference in the management for these type of varices. And what is IGV, or the isolated gastric varix? Sometimes we see that the esophagus will not be showing any varix, but there will be varices in the stomach. They are called the isolated gastric varices. And ectopic varices means they are beyond the stomach. With the Babino consensus and The goal of resuscitation is to preserve tissue perfusion, and volume resuscitation should be initiated to restore and maintain hemodynamic stability. Target hemoglobin of 7 to 8, and intubation is recommended. That's important. Intubation is recommended in patients with altered consciousness and those actively vomiting blood. Ideally, you should intubate the patient to prevent aspiration, and extubation as quickly as possible after endoscopy. That's what we aim at. And in suspected variceal bleeding, vasoactive drugs such as terlipressin or octreotide should be started as soon as possible, continued for 2 to 5 days in tapering doses. So this is just to show you, this is the appearance of the esophageal varices. And in the second picture, you can see the white nipple, and that is a suggestive of a reason that's called a red color sign. That patient has either blood or he can recently bleed. And in the third picture, it is the EBL. How do we attach the EBL? There's a shooter which we attach to this endoscope head, and then you can see the rubber bands. Usually they come as 6 bands in a strip, and you can deploy them in 6 places basically. And that is the EBL band. It is loaded there and it's ready for the endoscopy. And in the fourth picture, you can see that we have already banded a patient. That was a bleeding varix. You can see the red color signs there. And that was a bleeding varix, and now this is tackled with EBL. And this is just a schematic representation, just to know what was happening there. The site of bleeding, once we identify, we make a contact between our ligator and the varix. And what do you do then? You suck the varix into the ligator lumen, and then it is deployed. And you can see that ideally in the last picture, hemostasis would have been achieved. And once we do variceal ligation, we continue vasoactive drugs, provided the patient is not rebleeding. And the patient should always go for secondary prophylaxis with beta blockers. And we always go for a terminology called eradication of varices. It's not only once that we ban these varices. We should relieve these varices at the 3rd week after endoscopy, after the index endoscopy, and go for eradication. That means we have to make them very small. Varices have different gradings like 1, 2, 3, and we ensure that we go below a grading of at least grade 2, that is small esophageal varices. That is what we want at the end of the variceal eradication therapy. So this is Salin's classification of gastric varices. Just to introduce the terminology, Dr. Shiv Kumar Salin is one of the renowned hepatologists in India, and he is the person who has named the terminology comes after him. So we can see in the picture, it is easier to understand. You can see the GOV2. What is termed as the GOV2 is the esophageal varices. There's a continuity between the esophageal varices there, and it extends 2 to 5 mm into the gastroesophageal junction, and the varices are seen along the greater curvature. And GOV1 is along the lesser curvature. You can see the same thing extending into the lesser curvature of the stomach, and there is no connection. There are no esophageal varices. There is gastric varices in the absence of esophageal varices. We call it the IgB1, and if it is located still down, without esophageal varices, still down near the pylorus, they are called the IgB2. This is a common terminology which you might come across in endoscopy referrals. So here, lower down, we can see that's a GOV, that's a gastroesophageal varix. From the picture, it seems to be a GOV2, a large GOV2. That is, you can see an ulcer over there. So that means it has recently bled, and there are so many red spots there. So ideally, go in for a glue injection. Cyanoacrylate glue injection, that's what the endoscopist is trying to give. And in the second picture, they're telling that it's an isolated gastric varice, that we can understand only by seeing the esophagus also. If it is in the absence of, this one is called, in the absence of esophageal varices, it's an IgB1, isolated gastric varice. So usually we tackle them with glue injections. And this glue injection, another thing is that recently many endoscopists are giving it through the EUS, endoscopic guided ultrasound also. You can see the varices, the variceal lakes beyond this. This is the endoscopic view. So with endoscopic ultrasound, you can see large variceal lakes outside this also probably, and try to obliterate them with a glue and coil. They inject glue and coil into those large varices, but with the endoscopy, you can do only a glue injection of the cyanoacrylate. So this is just another picture of a gastric varix which shows that a recent stigmata of hemorrhage. And in cases where you are not able to tackle either of these varices, as we said in the algorithm, the patient goes for repeated rebleeds, then this is what we go for. That's a transjugular intrahepatic portosystemic shunt. Basically, we want to decompress the portal system. So this is a PTFE graft which we have kept between the portal vein and the hepatic vein. So this can decompress the portal system. Portal hypertension will be reduced, but with the caveat that it can lead to more episodes of hepatic encephalopathy. So a careful selection of patient with four tips can be done in cases of refractory bleeds, and this can be used also for refractory ascites and hepatic hydrothorax also. So this is another endoscopic picture. Many times you come across a patient, your patient of cirrhosis will be having significant portal hypertension and anemia, and then but they might not be overbleed. They can be overbleed also, but patient many times present with anemia, they will be having occult GI blood loss, which they don't appreciate, and we go in for an endoscopy and we see that this is the pylorus of the stomach. Actually, this is the outlet of the stomach. You can see the pylorus there at the rear. And this is what is called the watermelon stomach. So this watermelon stomach is typical for gastric antral vascular ectasia. And the second picture, you see that the endoscopist has tackled it with a modality called organ plasmacoagulation or APC. And many cases we have to go for repeated cases of APC in such patients if they are developing anemia again and again. Then another entity which we come across is portal hypertensive gastropathy, which is seen very commonly in cirrhotic patients during endoscopy. And there can be two stages to portal hypertensive gastropathy. Basically, it is described as a snakeskin appearance. You can see that the polygonal appearance of the mucosa, it looks edematous a bit. And in cases of mild portal hypertensive gastropathy, you won't see this much reddish spots. Most of the polygonals won't be having reddish spots in case of mild PAG. I didn't get a picture of mild PAG actually. This is a severe PAG where you can see that most of the polygons are showing red marks. So this is called, so this appearance of snakeskin is called a severe PAG. And this is also can be a cause of bleed and not as common as the varices, but then this can also cause bleeding, especially slow bleeding and anemia. And we can also use the modality which is commonly used here as the organ plasma coagulation. So coming to the ascites, so till now we were dealing with variceal bleeds. So how do we manage ascites? That's the next common decompensation process. So always when a patient comes with a fresh onset ascites, you see for the SAG. SAG is the serum albumin ascites gradient, and if the you are taking the difference between the serum albumin and the ascites and ascitic fluid albumin. So the point is that whenever you are doing a diagnostic tab for the patient with a new onset ascites, always send for a serum albumin also. There should be a corresponding serum albumin the same day. Otherwise, if you're taking the ascitic fluid today and you see the values and then you decide you need a serum albumin, you go for it the second day, the calculation is erroneous. Okay. So always take it on the same day, the serum albumin and the ascitic fluid albumin. Calculate the SAG. If the SAG is more than or equal to 1.1 gram per deciliter, 97% of the time you can say that the underlying etiology for the ascites is portal hypertension. And what is the treatment? So typically it is the high SAG, low protein ascites, what you expect in cases of cirrhotic ascites. That means due to portal hypertension. Ascites due to portal hypertension has a SAG more than or equal to 1.1 and low protein, that means mostly less than 2.5. If the protein is high, you suspect something like cardiac process underlying or a Budd-Chiari. And the patient with cirrhosis can have ascites due to many other reasons. For example, it might be tuberculous peritonitis. We said that they have a low immunity. So in such cases, they have a low SAG, high protein ascites. If it's a low SAG, high protein ascites, always send for ADA, always try to rule out a tuberculous pathology, or you go for cytology to rule out malignancies. So if it's typically high SAG, low protein ascites, 97% of the time you can be sure that it's due to portal hypertension and go directly for evaluation of cirrhosis and the treatment of ascites. So how do we treat ascites? It is by diuretics, and so ascites also has a grading. Like this, that is grade 1 is detectable only with ultrasound. You might not be able to demonstrate it clinically. In grade 2, that's a moderate ascites, you get the shifting dullness, and grade 3 is large or gross ascites. So in case of grade 3 ascites or in refractory cases of ascites where the patient is not responding to doses of diuretics, then you go for a large volume paracentesis. And for recurrent ascites, as we said, the TIPS is an option. So this is a grading. So how do you evaluate? Diagnostic paracensis is recommended in all patients with new onset grade 2 or grade 3 ascites. In those hospitalized for worsening of ascites or due to any complication of ascites. And then you go for a neutrophil count and culture of the acidic fluid. And try to do a bedside inoculation. That gives you the most culture positivity. And the neutrophil count, that is absolute neutrophil count. About 250 is required to diagnose spontaneous bacterial peritonitis. And a SAG should be calculated and cytology should be performed to differentiate malignancy later from non-malignant ascites. That is especially when the pattern is not as you expected, as we told earlier. So this is the European Association Society for Liver Disease. They say that the management of ascites grade 2 to 3, it has a poor prognosis, as we said, median survival up to 1 year. So always consider referral for LT, especially if the MELD is more than 15. And there should be another thing is you should always counsel the patient. You should take some time to talk to the patient about not only like it's not basically the prescription. You should talk about moderate restriction of sodium intake up to 4 to 6 grams of salt daily, and that means that there is no pre-prepared meal. Patient should be taking that much salt with them, and then they can put it according to their wish. That's it. So if you go for a pre-prepared meal, mostly in the Indian diet, it will be anyway more than 6 grams of salt. So what is large volume paracensis? It is a first-line therapy in patient with large ascites, that is grade 3 ascites. And we always should observe strict sterile precautions, and we see that the patient is going for an LVP up to 5 liters of ascites, then that's not problematic. But if you're going for, at the same syringe, you're going for an LVP of more than 5 liters, that can, the patient has a risk of developing what is called a post-paracensis circulatory dysfunction. So why do we fear this PPCD is the patient can develop AKI. That's a problem because it can lead to further reduction in the renal blood flow. So if the patient is going for an LVP of more than 5 liters ascites, always keep in mind that the patient may go in for a PPCD, that is post-paracensis circulatory dysfunction, and you give 8 grams per liter of ascites removed. That much albumin, sir. You should give that much albumin. So 8 grams of albumin per liter of ascites removed. So after LVP, the patient should receive a minimum dose of diuretic necessary to prevent reaccumulation of ascites. So you always tell the patient, or at least you should know that the drugs to be avoided in patient with ascites is NSAIDs, ARBs and AC inhibitors, because they can always further compromise. Then, I'm sorry, this is spelling mistake, aminoglycoside antibiotic, unless the culture says that it's only response to aminoglycoside, better to avoid them. And cautious use of contrast agents. Sometimes in the same patient, you might be suspecting a mass lesion, then you should be always, many times they don't develop a contrast-induced nephropathy, but just keep in mind that they can always go in for a contrast-induced nephropathy or an acute kidney injury if you're giving contrast. Now, what is called, another terminology just to introduce it, refractory ascites. Refractory ascites means it can be either a diuretic resistant ascites. That means the ascites is not responding to your sodium restriction and diuretic treatment, adequate doses of diuretics, or sometimes a patient can develop acute kidney injury and you are this electrolyte imbalance and you are not able to give even a moderate dose of diuretics to them. So that is called diuretic intractable ascites. So in either of these scenarios, it's called as refractory ascites. And we said refractory ascites, the patient going for TIPS. So another thing is the hepatorenal syndrome. The diagnostic criteria of hepatorenal syndrome has been defined by the IC, the International Club of Ascites, AKI guidelines. So whenever you see a patient with cirrhosis is having a raised serum creatinine, you always keep this in mind. The patient might be having either AKI or it can progress to hepatorenal syndrome. So how do you diagnose? The patient should be having, these are the diagnostic criteria 1 to 4. Diagnosis of cirrhosis with ascites. See for the baseline value, if there is an increase in serum creatinine of more than 0.3 milligram per deciliter from the baseline within 48 hours, or within 7 days if there is a more than 50% increase from the baseline value, and now the new criteria defines the urine output also. If there is a decrease of urine output less than 0.5 ml per kg for more than 6 hours, you can say that as a renal dysfunction. Then there should be the abscess. So then this is the stage of AKI. The second point, that's where we diagnose that the patient has an acute kidney injury. Now what we try is with volume resuscitation in case needed. How do we assess for whether the patient is volume depleted or patient is having adequate volume is by the focus. It's a point of care ultrasound, mainly by the measuring the IVC, or sometimes if needed we can do the echo also, and that is how we assess whether the patient is volume depleted. Now we try to give volume resuscitation. So if there is an improvement in any of these, like serum creatinine, if it does not improve, improvement means at least 25% from the value within 24 hours, or there is no improvement in urine output. Mostly we give IV albumin for this, for volume resuscitation. So if it is not improving in 24 hours, earlier it was 48 hours, now they say that within 24 hours if that is not improving, you can call it a hepatorenal syndrome. And always rule out alternative explanations as a primary cause of AKI, like septic shock or drug-induced. Whether earlier, as we said, patient might be taking some aminoglycosides or NSAIDs, always rule out a drug-induced cause, obstruction, or an acute glomerular injury. So, coming to SBP. What is SBP? The definition is bacterial infection of the acidic fluid without any intra-abdominal surgically treatable source of infection. Prevalence in SBP in the outpatients, even in the outpatients there might be 3.5% who has this, and see the percentage in hospitalized patients, it's up to 10%. So whenever you have a hospitalized patient, even the patient might be coming with a bleed, but the patient is having abdominal pain. Suddenly 48 hours the patient developed pain, abdominal pain, fever, distension, or sometimes even the patient can have altered sensorium, patient might be going for a shock. You suspect the patient has sepsis. That was why we gave this IV antibiotics for the patient with varicose bleed. No? That's why to avoid even SBP and sepsis. So if the patient has any of these, or if the patient has a worsening serum creatinine, then you see whether the patient has SBP, because it's more common than we think. And diagnosis is based on ANC of more than 250 and always a bedside inoculation and culture of the fluid, and roll out secondary bacterial peritonitis. So what's the first choice drug for SBP? It's a third generation cephalosporin or the piperacillin tazobactam. And when do we see for the response? Once we have taken an acidic fluid today and we started the patient on third generation cephalosporin or piperacillin tazobactam, and but for nosocomial SBP, so the patient had a recent admission with SBP, then you don't go for first choice as even picked as, you give meropenem. Then if there is a failure to decrease, failure of the ANC to decrease less than 25% of the pre-treatment value at 48 hours. So always repeat an acidic fluid. In case of SBPs, always repeat an acidic fluid at 48 hours. And if it fails to improve more than 25% of the pre-treatment ANC, that means it's a failure and you have to change the antibiotic. Duration of treatment is at least for 5 to 7 days, at least for 5 days. Then always give albumin. To prevent HRS, always give albumin. What is the quantity? Is 1.5 gram per kg at diagnosis, and on day 3 you give 1 gram per kilogram. And always on discharge, never forget to start your patient on prophylactic norfloxacin. Norfloxacin is the usual drug. Otherwise, we can use Septran also. And in some cases, we go for cycling. If the patient is developing SBP, recurrent SBPs on norfloxacin, we might give norfloxacin for 1 month, and then we then Septran for the next month, and then so on. It's called a cycling of the antibiotics for SBP. But usually it is 400 milligram of norfloxacin after recovery per day. Then, as we said, liver is very important for the innate immune mechanisms, and so we can definitely be on the watch out for bacterial infections other than SBP. So, what are the common? There are 3 common infections which come in cirrhosis patients: cellulitis, UTI, and pneumonia. So, always start on empirical antibiotic therapy. It can be also according to the institutional preferences or the MDROs. And always cirrhosis patient has what are MDRO? Multi-drug resistant organisms. So there is always a high chance for MDROs, because these patients would have gone for repeated hospitalizations and they might not respond to your first choice empirical antibiotics. So definitely culture is needed in all these cases, and you can always aim for a change of antibiotic once the culture report comes also. Then hepatopulmonary syndrome. I've just put a slide just to say what it is. So you suspect this when the patient with cirrhosis has tachypnea or digital clubbing or cyanosis. And how can you screen the patient? Like, you go for a digital pulse oximetry. If the SpO2 is less than 96%, if it is more than 96, you can safely say it's not HPS. Then if the SpO2 is less than 96, go for an EVG. and a PaO2 of lower than 80 millimeters of mercury while breathing ambient air, that lead to further investigations, and the investigation by contrast echocardiography, bubble echocardiography, and LT is preferred. Liver transplant, always refer the patient for liver transplant should PaO2 is less than 60%. And this needs exclusion of other cardiopulmonary pathologies also. So coming to the very important entity which we often come across in decompensated cirrhosis patients, that is hepatic encephalopathy. And as we said, the mortality is 1 year. After hepatic encephalopathy, the median survival is very less than 1 year. So what is it? It is a brain dysfunction caused by liver insufficiency and or photosystemic shunts. They can be either of these. Can be due to the hepatocyte insufficiency, failure of detoxification, or the patient might have photosystemic shunts, large photosystemic shunts which take the ammonia directly to the brain. It manifests as a, and in cirrhosis we call it a type C HE, and it manifests as a wide spectrum of neurological or psychiatric abnormalities that can range from subclinical alterations. It might be just an alteration of the sleep rhythm. The bystander might have noticed it in cases of covert hepatic encephalopathy, and the patient might be having a slow mentation. They're not able to drive or take decisions as earlier. So it can vary from those subclinical alterations to stages of coma in grade 4 hepatic encephalopathy. And so always in cases of hepatic encephalopathy, and they can be episodic or recurrent. So what are the usual causes? You should always check for whether the patient is constipated, whether the patient has any underlying infection along with the episode. Is there any electrolyte disorder? Usually we see hyponatremia very much associated with hepatic encephalopathy. The patient, does he have a diuretic overdose? And in cases of variceal bleeding also, many times you see that once you've tackled this even, they can go for a hepatic encephalopathy. So the treatment is identifying the precipitating factors. So always be on the watch of a GI bleed, infection, electrolytes, dehydration. Then the mainstay of treatment, one is IV, L-ornithine, L-aspartate. It's an ammonia scavenger. Then lactulose is also another thing which can decrease the ammonia levels. So what do we aim at? 2 to 3 sauce stools per day. So always in the patient is having hepatic encephalopathy, you always ensure that the patient, just ask the patient proactively whether they have 2 to 3 sauce stools per day. Many times we see that they don't see for that and they develop constipation, and on the 3rd or 4th they come with episodes of hepatic encephalopathy. And for recurrent episodes, that means more than 2 episodes of hepatic encephalopathy, you can go for a prophylaxis with a drug called rifaximin 550 mg twice daily. And always the patient has an increased protein demand, so nutritional support is very, very important in this patient. Then another complication is hepatic hydrothorax. It's accumulation of transudate in the pleural space of patients with decompensated cirrhosis in the absence of cardiac pulmonary or primary pleural disease. And what are the complications? Even though it's a transudative effusion, they can further develop SBE, that is spontaneous bacterial emphysema, and also they can go into sometimes respiratory failure. Treatment is diuresis, thoracentesis if the patient is having signs of respiratory failure especially. Then tips for recurrent symptomatic hyponatremia, that's one thing you should always, it's very important. And as we said, the melt was converted in melt sodium because hyponatremia is supposed to be an ominous prognostic factor in case of cirrhosis because it reflects a hyperdynamic circulation and splenic pathologies. So serum sodium concentration, how do we define it in cirrhosis? Usual cutoff is in defining hypertension 135, no? But in cirrhosis we aim at 130. It can be both hypovolemic and hypervolemic, but most of our patients will be hypervolemic hyponatremia. And the use of hypertonic saline, 3% saline in the management of hypervolemic should be restricted. The patient only has life-threatening complications and severe grades of encephalopathy. Aim at a slow correction up to 8 mg per day. And another class of drugs are the Bactins. They are B2 receptor antagonists, and they what they do is a solute-free diuresis in the kidneys. And but Bactins are not very much favored in this because many CTs have shown that the patient can go for fulminant hepatic failure, especially in advanced cases of cirrhosis. So another new terminology that has come up is frailty and sarcopenia in cirrhosis. Many we tend to ignore these things in cirrhosis. Actually, many of them will be malnourished because they'll be having fatigue and there's an inadequate intake of all the nutrients, and it's definitely a catabolic state also. And Even there will be a cognitive dysfunction that can add to this, and different etiologies of liver disease. And most of them, once they are decompensated, they will be having physical inactivity. They won't be moving around much, and all these will lead to muscle dysfunction. So frailty is an impairment of the functional capacity, and sarcopenia is a muscle wasting. So what happens when there is muscle wasting and frailty is that it can lead to increased decompensation, decreased health-related quality of life, death, and adverse post-transplant outcomes. So it's always important that you see for frailty and sarcopenia. What can we do? The management toolbox includes definitely a liver-specific treatments like management of disease etiology or ascites, whereby the patient can become more functional. But always tell your patients to go for one of these physical activity like aerobic or resistance exercises, and there are certain criteria how much to do and all. Then increased uptake. How much is the calorie intake? It's at least 35 kilocalories per kg, and protein intake of 1 to 1.5 gram per kilogram daily. So this is my last slide, liver transplantation. Then we have complications of cirrhosis. That's the ultimate treatment which we aim for, and especially at a MEL more than 15, not in a patient with MEL less than 15. So for complications of ascites, then refractory variceal hemorrhage, patient has hepatic encephalopathy. Even for the certain stages of hepatocellular cancer, you can advise the patient for liver transplantation. And another thing is, whenever you have a cirrhosis patient, even as physicians, if you have a patient with cirrhosis in your follow-up, always monitor for hepatocellular carcinoma. Many times we see that patient come with advanced stages of HCC where you don't have any therapeutic options to offer the patient. They just go for palliative care. So see that there's a routine monitoring for the development of hepatocellular carcinoma in these patients. And how do you do a screening is by ultrasound and also by a marker called AFP, less than 20. So usually if the patient has HCC, it goes about 200. So if the patient has a very high levels of AFP, or you see a lesion in the routine 6-monthly ultrasounds, so never miss a 6-monthly ultrasound for any patient, because keep in mind that up to 4% can develop HCC every year. And what is the investigation of choice? You cannot diagnose an HCC by ultrasound. If you have a suspicion by either of these criteria, go for a triple phase contrast enhanced CT of the abdomen. It always has to be a liver protocol. Otherwise, you can miss lesions, or you might not be able to define lesions. And there is a terminology called LIRADS. That's how the radiologist they give the report from suspected HCC cases for liver lesions in cirrhosis. So if the LIRADS is 5, it means that it's a definite HCC. So that depends on whether the lesion is an arterial phase hyperenhancing lesion with a portal phase washout. That's the typical. So APHE. Arterial phase hyperenhancement with the portal venous washout in a patient with cirrhosis can be diagnostic of HCC, and such a lesion will be reported as LIRADS 5 lesion. In case with the first imaging modality you are not able to know for sure whether it's an HCC, you go for MRI. And if both the modalities are not giving you a definite answer, it's not a LIRADS 5 in both of the modalities, and AFP is going up, you are highly clinically suspicious, then go for biopsies. But biopsy many times is not needed to diagnose HCC. So what are the take-home messages? Just keep in mind that cirrhosis can be asymptomatic in compensated cases, especially when you see a patient who has metabolic dysfunction like NAFLD, or patient is alcoholic. Just remember that early diagnosis is possible by the imaging modalities. Aim at etiologic evaluation and correction of the underlying etiology, whereby even at least in the early stages you can aim for a recompensation. Then clinically significant portal hypertension, that is the word, that's the most important predictor for liver decompensation. Then CTT and MEL scores for prognostication once you see the patient, timely identification and management of the complications which we have listed. Then always keep in mind to assess the frailty and sarcopenia, because it has so much implication in health-related quality of life, decompensation, even in the post-transplant scenario. Surveillance for HCC is mandatory in every cirrhotic patient, and there are emerging non-invasive predictors for fibrosis and clinically significant portal hypertension, such as the fibroscan or the many other blood-based scores. Okay. Thank you.